While the heart is responsible for generating the pressures needed to send blood to tissues, the blood vessels are what actually carry the blood where it needs to go and help direct it towards the tissues that need it the most. The vascular system is hierarchical, going from arteries to arterioles, to capillaries to venules to veins. Arteries and arterioles tend to have more smooth muscle and thicker walls comparative to veins and venules. Veins are highly distensible to allow them to store extra blood volume. Capillaries have very thin walls to maximize diffusion rates of wastes and nutrients with the surrounding tissues. The resistance and pressures in vessels mirrors their function. Large vessels are comparatively low resistance to facilitate bulk movement of blood. Small arteries and arterioles show a large drop of pressure across their length owing to the role they play in distributing blood to different tissues and decrease pressure in anticipation of reaching the capillaries. The traits of various blood vessels are largely dependent on the action of vascular smooth muscle. Vascular smooth muscle in the walls of the tunica media of blood vessels maintains a level of basal tone that can then be increased or decreased depending on the metabolic needs of the tissue that the blood vessel supplies. Increased tone, or vasoconstriction, will decrease blood flow through that vessel, while decreased tone or relaxation will increase flow. Vascular smooth muscle cells in a vessel are coupled together electronically and can be influenced by mediators in the surrounding tissue. But how exactly are they controlled? Well, there are a few controls in place that we can broadly categorize into local control and neurohumoral control. Let's take a look at local control first. Also known as autoregulation, it is the tendency of an organ to maintain constant blood flow in spite of changes to blood pressure. We have evidence this occurs based on the following observations. First of all, if we increase perfusion pressure to an organ, flow will rapidly increase. However, shortly after this occurs, flow will decrease back down to the baseline starting level of flow, even if that elevated perfusion pressure is maintained. The second observation is the phenomenon of reactive hyperemia. If we cut blood supply to a tissue for a short period of time, when we restore blood flow, the flow rate will temporarily rise above that of the baseline, pre-occlusion, for a time period roughly equivalent to that of which flow was cut. What's more interesting is that both of these phenomena are observable regardless of whether the vessels are innervated or not. This means that whatever is going on is happening at a local level. We don't know all the details of autoregulation just yet, but we do know the following. Myogenic control, a reaction where stretching of vessel walls triggers depolarization of the smooth muscle, causing it to contract. This allows counteracting of increased pressures to maintain a consistent flow rate to a tissue. Metabolic control. Many metabolic products are in fact vasoactive. Increased perivascular concentration of these metabolites can mediate vasodilation to increase blood flow to a tissue and promote removal of the waste products. Endothelial control. Increased blood flow causes shearing forces on vascular endothelium. Doing so triggers nitric oxide release, which acts via a cyclic GMP messenger system to decrease contraction, leading to vasodilation. What's interesting about autoregulation is that it doesn't occur to the same degree throughout the body. For example, cerebral autoregulation is very highly regulated, while cutaneous autoregulation is almost non-existent. So, we know about autoregulation, but what about neurohumoral control? Controlled by the autonomic nervous system, with some input from circulating catecholamines, the autonomic nervous system predominantly acts through sympathetic stimulation, as opposed to parasympathetic stimulation where vasculature is concerned. This is by and large mediated by alpha-1 and beta-2 receptors. Remember that alpha-1 receptors cause vasoconstriction and beta-2 cause vasodilation. Also remember that sometimes we want to divert blood flow to some organs and away from others, which is why we have sympathetic receptors that control both vasoconstriction and vasodilation. Our circulating catecholamines can also act on these receptors with the following effects. Noradrenaline causes vasoconstriction, except for in the coronary and cerebral vascular beds. By and large, it acts through alpha-1 receptors, and for this reason is actually our first choice of vasopressor drug for patients in cardiogenic shock. Conversely, adrenaline causes vasoconstriction of most tissues, but will also vasodilate skeletal and splanchnic vessels, due to acting equally on both alpha-1 and beta-2 receptors. The ability to raise blood pressure via alpha receptors, but also act on beta receptors, is why adrenaline is the drug of choice for anaphylactic shock. The alpha agonism allows us to maintain blood pressure in shocked patients, while the beta agonism increases cardiac inotropy, as well as triggering bronchodilation to maintain constricting airways in the shocked patient. Hopefully, what has become evident from this video is that the regulation of the vascular system is dependent on a number of mechanisms. When combined with the influences on the heart, this makes for a pretty stable system that is capable of responding to a variety of changes to demand. In all, I think that's pretty cool.